covering the midface and the following thing: a brief about embryology, osteology, and mainly surgical anatomy. So if we see embryology, we all know your face develops by 4th week of intrauterine life, mainly by these three prominences: frontonasal prominence, maxillary prominence, and mandibular prominence. So by 5th week, they grow and they take a turn into a craniocaudal direction. Means the embryo turns like that. So the face is directly opposing the pericardial bulge. So that time we have the development of lens placard, nasal placard, and as we all know, we have medial nasal process and lateral nasal process. And then it grows further, and your medial nasal process of frontonasal fuses with the maxillary process at the philtral level on the bilateral side, and your lateral nasal process goes up and contribute only to the ala of the nose. So this part is very important when we deal cleft and craniofacial anomaly. And by the end of 7th week, your maxillary process and mandibular process fuses and forms the cheek. So this is basic embryology. I hope everyone knows. Just a quick revision for that. And we have anatomy of the face completed by mainly these three processes involved by the completion of the 8th week. Now, these are the structure. I hope I need not go into detail of this. And these are the final outcome of your embryologic development. So now coming on to the midface. So half of my work is already finished by the previous speakers. I don't need to go in orbit, nose, etc. Mainly we'll be dealing with maxilla and zygoma and other few structures which are pertaining to the axis or approaches to the facial skeleton. So midface, we all know this part is viscerocranium and the other part is neurocranium. So if we minus mandible from the viscerocranium, compose the midface. So midface composed of bilateral or paired nasal bone, which is here, then paired lacrimal bone there. Then we have inferior nasal concha paired, again paired maxillae, and paired palatine bone, and the your bilateral zygomatic bone, and lastly your unpaired vomer bone, which I think we know very well by now. So this, yes. Okay. So now midface, these are the main bones which compose midface, in which majority of the thing is covered. Mainly we'll deal with maxilla and mandible. So maxilla is a very peculiar and a very unique bone in terms of processes. So if we see, it forms this maxilla per se forms and contribute to the major structure of the face. Like, it's not working, can you play? It's just a small, what? Let's change it. Directly from there. Yes. Okay, basically maxilla, if you see from the lateral side, it contributes to the lateral wall of the nose and the floor of the nose. If you see from the superior side, it contributes to the orbit or the orbital fissure, infraorbital fissure on the medial side. Also, if you see from the inferior part, it contributes to the roof of the mouth, that is the palate. And if you see from your posterior angle, it contributes to three major fossas, that is pterygopalatine fossa, your temporal fossa and infratemporal fossa. So all the majority or the major anatomical landmarks that is associated with some or the other way with maxilla. So now articulation of the maxilla, very briefly we'll discuss the articulation. It is paired bone which is connected in midline with, this is also a video, can you play? Okay, yeah, it's getting played. So it is a paired bone which is joined in midline with the help of intermaxillary suture in the midline. And how does it articulate with the other bones in the facial skeleton? So from the superior end, if we see, so superiorly you have three major bones which is attached to maxilla. We all know them. It is your maxilla is there. Now you see the attachment. One is nasal on both the side. This one. Then you have frontal and then lacrimal bones. That is the superior aspect of the articulation. Then laterally it articulates with zygoma. Then if you come little down, that means this side, it articulates with, okay, so here it articulates with your palatine bone and your inferior nasal concha and of course vomer at the coming on to the structure of the maxilla. So maxilla has a body which contains sinus, we know it, and we have processes. So we have frontonasal process, this side, okay, this is the body showing housing of the maxillary sinus. Then you have a frontal process, also known as frontonasal process of maxilla. Then we have, it's playing, no? Okay, so this is your frontal process or frontonasal process. This is your zygomatic process. This is your palatine process on the this side, and you have a alveolar process. The frontonasal process only contributes to the orbital part. Some people say there is an orbital process. It is nothing but the extension of the frontonasal process of maxilla. So this we have seen, and these surfaces contributes to these structures. So the superior surface of the maxilla contribute to the orbital part or the orbital surface. The anterior becomes the anterolateral aspect of your sinus. Your posterior aspect becomes the infratemporal aspect of your sinus, and your nasal becomes the medial aspect, forms the lateral wall of your nose. We all know the blood supply, your venous supply and nerve supply. Mainly the surgical anatomy of this venous supply is important. You all know why? Because it contains pterygoid venous plexus at this area, which is a commonest route to get infected or source of hematoma if you puncture accidentally. So that you need to take care not to go beyond. So we all know in PSA we don't have to go beyond 16 mm, so that we avoid that puncture. Nerve supply. And these are the attachment. I think we have dealt nicely with the attachment. I am not going into detail of the muscle attachment on maxilla. So moving on to the zygomatic bone. So now zygomatic bone is very crucial when you have to reconstruct the face, because it is the main basis of your width or the facial height of a person. These are the different angle how zygoma will, like you can appreciate from the inferior angle, so your anterior and lateral. It's like a star-shaped bone. It is said as quadrupod, but some people also say it is 5 processes. It has 5 processes. Many books also suggest 5th process name, but it is not universally accepted now. So right now the concept is 4 processes of zygoma. So in this we have zygoma. It will work. Okay. So can you see the zygoma? We see the articulation. It articulates in the orbital surface with the maxilla here and forms the orbit. Means the compose the wall of the orbit on the lateral side and the inferior lateral side. Then we have contribution on the temporal side via temporal process of the zygomatic bone and forms the arch. Then again, can we fasten it? Okay, so inferiorly we have articulation with your maxilla via zygomatic process. Posteriorly we have sphenoid, and superiorly we have frontal. These are the articulation of your zygoma. So can you see it's a star-shaped bone? Like many author claim zygoma has a 5 processes. So right now established thing is frontal, temporal, maxillary and orbital. They also say the this process, they also say sphenoid or ethmoid process, which goes backward. These are the major muscle. We all know it is the main muscular attachment for the levators of the upper lip. Okay, so all the major elevators of your upper lip, that is zygomaticus major, minor and levator labii superioris. Alekinezi comes to the frontonasal process of the maxilla, doesn't go to the zygoma. So blood supply, nerve supply, it all comes from maxillary artery and your V2 branch of trigeminal nerve. This is the main part why we are here, because to approach the midface we need to know the major surgical anatomy of the midface. So first thing, I think major PG question, everybody are very well versed with this thing, buttresses of the facial skeleton. So in any case you have some pathology or trauma or something, you need to reconstruct the buttresses. So like this hall, we have few beams and pillar. So if this hall collapse, God forbid, so if you want to rebuild it, you need to rebuild the pillars and the buttresses. So that's your horizontal buttress and vertical buttress. So it goes from horizontal buttress goes from this part. This is the frontal bar. Horizontal buttress is this superior, which is the frontal bar. Then here it is the infraorbital rim. Bilateral side forms the second thing, and then the hard palate, because these are the thick corticated bone which provide support to the midfacial skeleton. Mandible we are not including, already we have finished it. When it comes to your vertical buttress, this is your nasomaxillary buttress. Then you have zygomaticomaxillary buttress, which if you see it from the lateral side, it is continuous with the arch also. And then you have pterygoid buttress, and again the rim of the mandible forms the one more buttress, but not including here. Next important concept in midface is you need to know the importance of this. So it is something when you want to see it, it will get hidden. When you don't want it, it will come and show, yeah, I'm there. Okay, so that is the kind of a structure we have. So traditional pictorial representation of buccal fat pad till 2024 was something like this. It goes like till temple and all, like it's an elongated structure. But in 2024, it has been proven by this person that along with the evidence on the cadaver and in person, it is not having an extension as it was supposed to be shown in the previous articles or books. It is something like this. So this is very recent modification what I have come across, especially for the GAN. I also got to know this thing. So it has 4 processes. One is your pterygoid, pterygopalatine, temporal, which is again divided into superior and deep, and this side which is most commonly we engage is the buccal. We take out always buccal. Okay, so here this you have seen. Now one more thing I want to emphasize here, the parotid duct and the parotid fistula, your papilla. That is also important. When you suppose for a oroentral communication or a fistula or for anything, if you want to harvest it, you need to know the relationship of the parotid duct to your buccal fat pad and also the relationship of the facial nerve. So it has seen that it is 3 types of variation are seen mainly. Type A, where the parotid duct is anterior to it. It is not involving with the substance of the buccal fat pad. In type B, it is passing through it, and in type C, it is posterior to the buccal fat pad. So always while approaching, I think we'll discuss in the approach this furthermore. So right now I'll move ahead. And now the relationship of the buccal fat pad to the buccal branch of facial artery. That is again an important thing. So 2 variants are there. One is it doesn't involve the buccal fat pad, and another is 2 tweaks of the buccal branch of the facial nerve passes from the substance of buccal fat pad. So if it is there, you need to be careful. So now moving to the interplay between the skeleton and the soft tissue. Again, very important concept. All your I think Rahul sir has spoken about SOOF and all such things spaces. You will get a little clearer idea here. So this is mid-cheek anatomy, which is divided into 3 parts. One is just below the lower lid. One is just below the your lower eyelid, that is lid cheek region. Then you have malar region, and then you have nasolabial region. All this unit is important in terms of reconstruction. So whichever reconstruction you are planning, you need to exploit or basically take advantage of the units available, and it will give you reconstruction nicely. So this I think we all know by now is mass layer and the layer of the face. Basically they are there to form a multi-link fibrous system. It's like a stem holding all together things. So the main stem and the leaves and the reticular part is connected with the help of a SMAS layer. But there is a major difference of your scalp ka layer mein and face layer. So basically scalp, we all know it is 4th layer is the most loose layer, a very easy surgeon's friend. Even without an instrument you can dissect with the blunt dissection, right? But 4th layer in face is the most difficult layer to dissect at places, not everywhere on the face, but at places, because it contains many things which I'll be discussing. And there are 2 important things again here also. The layer of the scalp, layer of the face will be different in your skeleton, like where you have a zygoma. On a skeleton, layer will be different. On a cavity, layer will be different. Like orbit, layering is different. Oral mucosa, layering is different. So here it contains, so your 4th layer I am talking about, only 4th layer, it contains retaining ligament of the face, which we utilize at the time of facelift, because we engages those ligament to get the plication or the excision, whatever. Because if we only tighten the skin, it will give away. So this is that retaining ligament which contains of septae, adhesions, and some true ligament, which is zygomaticus ligament, your mandibular ligament, which are true ligaments. And see, this I was talking about. If you see the anatomy over a bone, it has entire 5 layer including the periosteum. If you see over a cavity, it is 3 layer again covering with a mucosa. So that is the difference between the layering over a bone and layering on a socket or on a bony cavity. So now here, subisthmus layer, again few places it is easy to dissect because it gives a nice avascular plane and not much thing that is in the bony cavity, and you need to see that spaces are like these. If you find, okay, I'll tell the space, I'll show the space later. These few things, that retaining ligament I was talking about, this is zygomatic ligament and orbicularis ocular restraining ligament. These are the ligament we see when we go for the aesthetic procedure or even trauma. Suppose we are exposing a vestibular incision. If we don't address these things, your face will just sag. Like orthognathic, all those things we'll discuss how it affects your surgical outcome. So this is that spaces, like this one, it is pre-zygomatic space which is present inferior or anterior to the zygoma below the muscle. This is the same thing shown in the cadaver. Same thing, this is that space which is these area. Okay, so this is that area, that space which is devoid of a major anatomical structure, that is souffle, which we can play around just below the lower eyelid, and it also forms the compartments of the face. Your orbit ka fat doesn't come to the cheek, cheek ka fat doesn't come down. So this is pre-masseter space which is present anterior to the masseter. That is again one space which we can utilize, which we might see in some video if we'll see. And again, one very important thing, your face is divided into the anterior aspect of the face and your lateral aspect of the face. So who divides that partition? What is the thing which is dividing anterior aspect and the lateral aspect? If you see any space infection, your swelling doesn't cross that boundary. Whereas in mandible it crosses. Whereas in midface it doesn't crosses the anterior split doesn't crosses the lateral thing. So these are the thickening fascia, like the thickened fascia at very particular places, like especially in the angle of the mandible you have platysmal auricular fascia. It is very adherent to your angle. So that is one thing. So even in your space infection, it doesn't crosses the posterior border. It goes down and elevate the tongue, but it doesn't crosses your posterior border of the ramus. So from my side, few take home message what I want to give is, you need to respect those layers, those spaces, those ligament if you want the patient to be as before. That is one thing. You always utilize the spaces, and whenever there will be a muscle, there will be some space will be related to that muscle if that is a major muscle. One more thing is, all your shape of your facial skeleton is not only dependent on the skeleton. It is equally important to give importance to your soft tissue, to your muscle, to your ligaments and to your spaces. So I think it was just a trailer. We have just introduced mid-face. I think we are ready to take off because Deepesh sir will take you off with the approaches and the videos. So thank you so much.
Can I just ask you one simple question? What exactly is the function of your retaining ligaments you just mentioned?
Basically, basically those spaces provides the interplay of the skeleton to the soft tissue. See, our face has a hard structure, like skeleton is there, but all our facial muscles are moving. So there is a mobility in the entire mid-face, which is not there with the other thing. So this mobility kahan se aa rahi hai? So that something has to be glide onto someone, right? I don't know, are you getting me or no? Are you getting my point, what I am trying to say? To get a dynamic movement or to get a facial expression, there should be a space or there should be something on which muscle glides so that they produce expression. So the gliding plane is those spaces and the compartments of the face. Have I answered your question, sir?
I think I have another perspective to this. Okay, can I just explain this, sir? So actually, the retaining ligaments, they are like, this is bone.
I am not covering aesthetic part.
No, I'm not talking about aesthetic part because it's going to be important for the patient. So basically what happens is, these retaining ligaments, they would go from the periosteum and they would get attached to the skin. So the main function is it holds the skin in that place. So now when we start getting older, the superficial fat pads, they start dropping down. So basically there is an attenuation of these ligaments, which kind of allows this the whole of the fat to get down. It starts falling down because the retaining ligaments which are there, they start getting attenuated. So I think when he is talking about midface, I think that
approaches. Actually, we have intentionally left that part for tomorrow because if we covered that part, then
nothing will be left for us.